I think the Twilight and the Onyx 1 studies were important trials to talk about how we can either shorten the duration of dual antiplatelet therapy, and of course in Twilight, which was the largest prospective randomized study in a double-blind placebo fashion, to drop aspirin for the first time in patients in complex PCI or complex patients and lesions undergoing a percutaneous coronary intervention. So Twilight showed that if you choose the patients in whom you want to give aspirin ticagrelor after a PCI, and if you watch them for 3 months on aspirin and ticagrelor, at 3 months, you can evaluate them if they are compliant and they did not have any events like bleeding or severe bleeding or an ischemic event like myocardial infarction or need for another revascularization, then you can choose to treat that patient with ticagrelor monotherapy. And if you do that, you will reduce bleeding compared to leaving them on aspirin ticagrelor for 12 months. You will reduce bleeding and you will not cause any harm at all. So it just seems like a viable option in those patients that I just described. In Onyx 1, I think was the largest randomized study of 2 stent platforms with very, very high risk patients, high bleeding risk patients, and they only received 1 month of dual antiplatelet therapies and went to a single antiplatelet regimen. And they showed that these 2 stent platforms are safe and effective in reducing, because already the biofreedom stent was shown to be superior to bare metal stents. So bare metal stents are out for high bleeding risk patients, and you can now choose either the biofreedom stent or the Onyx stent and just give 1 month of that. They were similar. Well, the guidelines are going to have to be kind of, I think, revisited after all of these trials. And at the moment, the high bleeding risk patients are those who are on oral anticoagulants, elderly, anemic patients, etc. But the Academic Research Consortium recently put together in a consensus way criteria that we hope everybody will use for high bleeding risk. And there are major and minor. You need at least 1 major or 2 minor criteria to get on there. And in fact, interestingly, age over 75 is a minor criteria. It's not like all elderly patients are at high bleeding risk. So we need to kind of hopefully use those criteria for high bleeding risk and then revisit whether or not they're validated and do they really translate into that high bleeding risk patients, or the ones who are not in there, are they actually at low risk? So it's very important. Well, yeah, so it's a very, very good question. And your question is, how do you plan a strategy for your patients at high bleeding risk after PCI? What do you do? Who gets 1 month? Who gets 3 months? Who gets, and it's a big, big question. And I think what you have to do is to really take into account the ischemic risk first and foremost, because if you have a high burden of ischemia, it's just as important as the bleeding risk. And making sure that you make those evaluations in a very, very good way so that you are not rationing good therapy in patients who need it for ischemic protection, or you're not exposing patients to undue bleeding risk in a low ischemic burden patient. So very important to make those assessments, have a good conversation with your patient, to do very close follow-up, and to assess the risk of ischemia versus bleeding, and then make those important choices. I think in the patients with an oral anticoagulant, there's good evidence that a novel oral anticoagulant is better than vitamin K antagonists in most cases for protection of and less bleeding and good stroke protection. I also think that when in those patients who have PCI, you can drop the aspirin as soon as possible. I think that is a very, very important new finding, and hopefully we can get that into the guidelines as well. Yeah, so, emergency PCI is a different story, right? I mean, I think we just move ahead. We hardly, at that time, you really are there to save a patient's life. And so, yes, but once you did your procedure and saved that patient's life, then you start to think about the strategies and then take into account, I think, on the in the peri-procedural section, anybody who's a high bleeding risk, you should use radial access. You should not be using 2B3As unless you need it. You should be careful about, but the potent agents, might be really effective early, and you basically protect them against the ischemic risk, and then you might not give it to them for a long period of time. So these are the kinds of things that we would take into account when you have an emergency procedure in an elderly patient who you find is on an oral anticoagulant, as atrial fibrillation, et cetera. So there are important procedural things that you can do to protect the patient as well that you should be doing.